It is my honor and the pleasure this night to have one of the greatest stars. He is Egyptian, and I am very proud that Professor Osama Hamdy is Egyptian, not only Egyptian, but graduated from the same university, Mansoura University. And I'm sure this night will be fantastic. And Professor Osama will speak about new techniques in nutritional therapy. I am very fond of nutritional therapy because I am believing in diet and disease relationship. This night we have two elegant figures in the field of endocrinology, diabetes, Professor Megahed Abuelmagd, and nephrology, Professor Samir. I'd like to introduce Professor Osama. And this is the research profile on Scopus with HNX26, which is very valuable figure. And he has more than 90 documents and cited for more than 4,000 times. So this is a very nice research activities. And this is just a sample from the research of Professor Osama Hamdy, one of the very recent publications about effect of dairy consumption and its fat content on glycemic control and the cardiovascular disease risk factors in type 2 diabetes. And this is a randomized control trial, very nice study. I'm not going to conclude or give comments on the research, but just highlighting some example. And this is one of the articles about the use of diabetes-specific nutritional shake to replace a daily breakfast and afternoon snack. And here we have Professor Refaat Hegazi, and I'm very proud that he joins this session, and he will contribute to the discussion after the presentation. Another article about the cardiometabolic risk factors. So a lot of issues, and this is nutritional therapy for Ramadan, which we are interested as Muslim by absolute fasting in Ramadan, how to handle nutrition. And this is one of the very fantastic articles about patient-driven diabetes care of the future in technology era. I like this figure very much because everything can be digitalized and the patient brought on board and sharing his treatment. Also fat versus carbohydrate, and I'm sure this will be very nice point, and I think it will be addressed in many questions about keto diets. And I like the approach of multidisciplinary team approach for weight loss, starting from the patient, from psychologist, from exercise and drugs, and at the last resort is bariatric surgery. All the time, we love to meet Professor Osama Hamdy. He is in the heart here with Professor Samir, Professor Megahed Abuelmagd, and Professor Saeed. This photo since 3 years, I think, since 3 years, when Professor Osama Hamdy came to the Faculty of Medicine and had the title of Honorary Professor at Faculty of Medicine, Mansoura University, the mother of the graduation. We have Dr. Megahed. Always we enjoy presentation of Dr. Megahed Abuelmagd, and this was the last presentation in August about thyroid renal axis. Professor Samir about water treatment dialysis in August. So this night we are waiting and eager to hear from Professor Osama Hamdy a lot of information about new technology in nutritional therapy. And this photo we have the Professor Onem, the leader and the founder of transplantation in Egypt. So we are happy to have Professor Osama Hamdy with us. And for this session, I am glad that Professor Refaat Fattah Hegazi joined this session. And as Professor Osama Hamdy mentioned, that he's not interested, but he is he has a depth in research, and this is his scopus, fantastic research, and I'm sure that he will be he will enrich this session. So I'd like to end with this slide. We are eager to hear the novel nutrition techniques, and the title is very exciting, and I would like to congratulate Professor Osama about the title. Can we radically change the course or cure chronic diseases So we are eager to know. And before I'm leaving, I would like to announce that in all our CME meetings, we have nothing to declare, no industrial promotion, I should stop here to allow Professor Osama to share his slides and to start his presentation. But before his start, I'd like Dr. Megahed, Professor Megahed Abuelmagd, just to welcome Professor Osama in a minute. You can share your slide, Professor Osama now. Dr. Megahed.
Okay, first I would like to thank you, Dr. Hussein, for this amazing introduction. And I'm honored and pleasure to present today some new information, but most of my honor also and pleasure is to do it in the presence of my wonderful colleagues, Dr. Megahed, Dr. Samir, and Dr. Refaat, and all our colleagues in Mansoura, in Africa, in Egypt, and the Middle East. I bet you are here to hear something new, and what you will hear today, or big part of what you will hear today, is presented for the first time, even not in the United States before. So you will hear a lot of new information and new ideas. But let me first start from here. In the last few years, you all know, let me just move this a little bit later because, you know, we need to start something even more exciting at the beginning. So let me have this here. You know, Hippocrates, the father of medicine, said, let the food be the medicine and let the medicine be the food. And many years later, Prophet Muhammad said, the worst place that you can fill is your stomach. And he said also, fasting is a cure for all diseases. So there is a lot that had been rooted in food that can be used as treatment. And we are talking these days about what's called the medical nutrition therapy. And medical nutrition therapy in reality is how you can use nutrition as medicine. And if we go back in the history of diabetes to Frederick Allen and Elliot Joslin, those are the fathers of diabetes management. You will see that they were very, very successful in treating diabetes by nutrition. And this way before all the medication that we are using right now for diabetes, whether insulin or the 47 other oral medication and injectable medication for diabetes. And both of them in the old days wrote very nice textbook. And as you can see, both of them published this in 1919. And it is very, very interesting how when you see those books and what is written in them, because the amount of knowledge at that time was huge. And the reason for all that knowledge at that time is that there is no medication that they can use to treat a disease like diabetes. So for example, total dietary regulation in the treatment of diabetes, this book is 780 pages about how you can treat diabetes by nutrition. So imagine during that time that much knowledge had been there. And what those people used to do is to give people the exact amount of carbohydrates, exact amount of fat, exact amount of protein to treat diabetes. And interestingly, both of them wrote in their books, we were able to cure every single case of fatty diabetes. This is what we call it now, type 2 diabetes. And mind of the word, they didn't say treat those cases, they said cure these cases. Which means that after the implementation of their nutrition techniques, patients didn't have diabetes anymore. And what they did, they admitted people to the hospital. They give them zero amount of carbohydrates in the first day, and they start to increase carbohydrates gradually to 120 to 150 grams of carbohydrates over 15, 20 days. And during those days, they used to evaluate every single aspect of metabolism. And when they start to see that the metabolism start to shift, then they say, this is the amount of carbohydrates that you cannot exceed. Could be 50 grams, could be 100 grams, it could be 20 grams, whatever it is, this is the amount. And then they give them enough amount of protein, and they calculated that protein and found it 0.6 gram per kilogram. But this was the foundation of precision medicine. And those people did it very, very well and had been very successful. And that regimen continued to be used to treat diabetes for several years. When insulin was discovered in 1922, you'll be surprised that a lot of people refused to use insulin for treating those fatty diabetes because they found that nutrition was very effective. But as you can see, Louis Newberg, who's one of the biggest researcher at that time in nutrition, said that the discovery of insulin was a severe setback to the advancement of the science and art of nutrition. And nowadays we are medication centric. We focus on using medications more, but in reality, and I will show you in this presentation, that a lot of things can be done by nutrition to a degree that you can cure many chronic diseases, including diabetes, cardiovascular disease, and even cancer, and autoimmune disease, and some neurological diseases, and some bowel diseases. So 2016, I published an article in New York Times, and the title of the article was very interesting: the old-fashioned way to treat diabetes, a better diabetes treatment. And this evoked the whole era of reducing carbohydrates in the diet of people with diabetes, because what we said at that time is that diabetes was defined as a carbohydrate intolerance disease, and if we will able to reduce carbohydrates and change the type of carbohydrates, this can change the future of diabetes. But what we are talking about these days is not just food. We are talking about eating patterns. And you can see several eating patterns had been shown to have some benefit. Mediterranean diet, vegetarian diet, low fat, very low fat, low carbohydrate, very low carbohydrate, DASH diet, which is mostly for hypertension, and paleo diet, which is mostly protein. And you can see in many aspects, those diets had been of some benefit. In diabetes, reduction of the risk of diabetes, or reduction of A1C, of cardiovascular effect, or triglyceride, or HDL, or LDL, or weight, or blood pressure. And you can see variability in the effect between those types of dietary pattern. So we started to move from one concept of dietary pattern to a much more precise concept. And one of the precise concepts that we know for now, that if you aim for weight reduction, there are three ways new and had been very effective in weight management: intermittent fasting, low calorie diet, and ketogenic diet. And I will focus a little bit here in this presentation about intermittent fasting. But in diabetes control, there is also low carbohydrate diet and a structured nutrition plan. I will also give you some hint about structured nutrition plan. But most of my presentation will be on a new concept: reversal or cure of chronic disease. And this now is not by nutrition, is not by eating, it is by fasting, water fasting, or what's called fasting mimicking diet. And fasting mimicking diet is to give diet which the body will perceive as fasting. And I will spend most of my presentation on those, but I will just give you a hint of what we did before that lead to that concept. So here is a structured nutrition plan. What means by structured nutrition plan? A structured nutrition plan means that you give a certain percentage of macronutrients, carbohydrates down to around 40% instead of 50, 60%. And it is low glycemic index carbohydrates, has more fiber. And then fat is between 30 and 35, but saturated fat is less than 10%. And then increase protein up to 1 to 1.5 gram per kilogram of body weight, and more fiber, around 14 grams of fiber per 1,000 calories. So you take that structured nutrition plan and you give it in the form of nutrition, natural diet in the form of dinner menus and snacks. So you give people dinner menus or snacks, or you give them in the form of a diabetes formula. So this is a formula that has exactly that same structure and has defined the calories and defined macronutrients, and also fortified with vitamins and minerals. So if you give this plan, we found that it is very effective in controlling diabetes and also in helping people to lose weight and maintain weight loss. And last year we presented data that those people were able to maintain weight loss for 10 years. So can you imagine 10 years? And the weight loss was maintained around 6.9% weight loss. So what is the nutrition formula? Because this is also a very interesting concept. So if you take a special blend of amino acids that compose the protein and you give it to patients with diabetes in the form of diabetes specific formula, you will have huge impact on many aspects of the disease. But not only that, it has a lot of effect on gastrointestinal hormones, whether these hormones are insulin, GLP-1 hormone, amylin, PYY hormone. So to test this, and this is the first test of that effect, we took around 22 patients with diabetes, and they have diabetes for almost 10 years. And what we did, we give them nutrition meal, which is in the form of oatmeal, 200 calories, and then we give them in the same, in a different day, another 200 calories using the diabetes specific form. And when we give them the oatmeal in red, you can see the blood sugar went up and then down, and significantly up around 180, but after 1.5 hours. But we didn't see that increase in the blood glucose level when we give this diabetes specific formula. In reality, the glucose area under the curve was down by 71% for 4 hours. This is very interesting. Why amino acids and why protein will do that job. So what we found, which is very interesting, is that when you give that blend of amino acids, you increase GLP-1 hormone. This is a hormone that we use now to treat diabetes and obesity. And it went significantly up. It went up 12 times higher. So can you imagine, we are giving our patient medication now, which are very expensive to treat diabetes, to preserve GLP-1 by suppressing DPP-4 enzyme, or by giving them analog of GLP-1, but just giving them blend of amino acids in protein formulation, and then you can see significant increase in GLP-1. Again, we found a very interesting increase also in PYY. PYY is a very strong satiety hormone, 25 times higher PYY by this blend. So GLP-1 went way up, and the PYY went up. Not only that, we also found the amylin hormone, which is a hormone that suppresses glucagon and suppresses hepatic glucose production, went also significantly up. So it looks like by giving certain nutrition in the form of diabetes specific formula, you can evoke several important hormones from the GIT to lower blood glucose level and to induce satiety and help people to lose weight. Nowadays, the American Diabetes Association put it in the standard of care in 2020 based on our research, and basically suggesting that people with diabetes will get very good benefit from low-calorie diet and also meal replacement. And this is given in the form of medical nutrition therapy in a structured nutrition plan. And they say that is strongly recommended because this is a beginning of precision medicine to help people to lose weight and control diabetes. Then came the whole new concept of intermittent fasting. So intermittent fasting, similar to simply what we do in Ramadan when we fast. It is either timed fasting or reducing the entire caloric intake. But why fasting had been a center of interest? If you read this article, which was published very recently last year in New England Journal of Medicine about intermittent fasting, you will find that intermittent fasting has an impact on several organs in the body: liver, stomach, adipose tissue, brain, heart, and blood vessels in a very, very efficient way. How this happens? So what we know right now, and I think this is very, very important, is that all of you know that the mitochondria is the core of the cell. This is where oxidation, metabolism occurs inside the cell. And the major reason for aging is that the mitochondria over time get dysfunctional. So dysfunctional mitochondria lead to aging, leading to chronic diseases, and also leading to certain types of cancer. And the way to preserve mitochondria is very, very difficult. That's why people ultimately age and die. But they found recently, which is very interesting, that if you expose the body to a period of fasting, and that period of fasting is prolonged for quite some time, that stress that occurs here will rejuvenate the body. Some of the old cells will die and some new cells are formed with healthier mitochondria, but it also restore the function of the mitochondria. So intermittent fasting is very interesting, and it is advanced to a total fasting or fasting mimicking diet, but at least we understand now why intermittent fasting is very effective. It is a lot of research that has been done, and the researcher, one of them, got Nobel Prize for their discovery. So what we found in when people exposed to intermittent fasting, it improved insulin sensitivity to the maximum. It reduced hepatic steatosis. Mind that 60–70% of people with diabetes have hepatic steatosis, and some of them even have NASH or cirrhosis. And then it improved glycemic control and reduced body weight. So multiple benefits you can get from intermittent fasting. So how people can do this fasting? Just in a quick review, there is what's called the 5-2, and 5-2 is that you eat for 5 days, and fasting 2 days is basically you take a very low calorie diet, 500–700 calories only, but you distribute them during the day. This is the simplest way that people can do. The other common way is 4 days, 4 days of eating and 3 days of fasting. But this fasting is timed fasting. So fasting for almost 16 hours. So you eat the dinner, and from the dinner you don't eat for 16 hours. But you can drink water. You limit it to the amount of caffeinated by just 1 cup of tea or coffee. Can be done, and then after 16 hours you start eating in normal way, and the other 4 days you eat in normal way. Then at Joslin we modified this a little bit, and we made a hybrid between the two. So this is called 4-3, very low calorie. So the same way, 4 days you eat, 3 days you fast 16 hours. But in those 3 days, you don't eat as you like. You eat only 500 to 700 calorie diet. So this is even more powerful than this one. And then the more advanced system is 4-3, but during those 3 days, you don't eat at all, zero eating. And you will be surprised when you have zero eating and just drink water. This will have huge impact on the cell, both the cells of the body under extreme stress, and suppress the nutritional pathways and rejuvenate cells back, if people can do it. And then there is a more advanced system. So the more advanced is fasting and fasting mimicking diet. So fasting mimicking diet is another concept. As I mentioned, this is to give.
In this presentation, we will dive deeply in the science of fasting mimicking diets. So why mimic a fast? You know, regular fasting is what's called water fasting, that you just drink water but you don't eat, has a lot of drawbacks. Blood sugar can go down, hypoglycemia can occur, blood pressure can go down, hypotension can occur, it lowers immunity, it may cause malnutrition, it causes physical weakness, but above all, people cannot adhere to water fasting for longer duration. So let me now give you an example of the composition of fasting mimicking diet. It is lower in protein. Protein is only around 9 to 11%. It has plant-based fats, including omega-3, and the ratio is around 44 to 46% of the total caloric intake. It has complex carbohydrates and fibers, again around 43 to 47%. But it's also calorie restricted. So the only calories that your body will get is around 700 to 1100 calories per day. It also includes all the micronutrients that your body will need. So there will be no reduction in vitamins or trace elements or essential minerals. Those are all included, plus glycerol. And the formulation is intended for down-regulating the nutrient sensing pathway. So it will down-regulate that pathway, but in the same time, stimulates stress-resistant mechanism, which should promote autophagy and cellular rejuvenation. Since the topic is new to most of you, I thought to cover some of the research that had been done in animal studies and in pilot human studies, which will direct us in the future to see what FMD can be used for. Mind that there is no indication in any disease right now, but effects on human remain to be validated through clinical trials. And I prefer as well randomized clinical trial to give us the full information. So published and preclinical research sheds a light on the potential impact on fasting mimicking diets in animals and pilot studies. Of course, the first was the longevity, which attracted a lot of attention on the benefit of fasting and fasting mimicking diets. But also there is data on diabetes, cardiovascular, autoimmune, neuro, and cancer. And I will go through them in much more details in a few seconds. So now let us talk about the clinical evidence behind the fasting mimicking diets. So let me start with the effect of fasting mimicking diet on diabetes. So as you know, diet of metabolic disorders, which is characterized by hyperglycemia. And the reason for hyperglycemia is relative insulin deficiency or insulin resistance, or both of them. Basically, the action of insulin on the target tissue in relation to the metabolism of carbohydrates, protein, and fat is abnormal in people with diabetes. As you all know, type 2 diabetes, which is a predominant type of diabetes, is related mostly to obesity, especially obesity when it occurs in the central area. This is what we call it visceral obesity or metabolic obesity, accumulation of intra-abdominal fat, which leads to insulin resistance. And after that insulin resistance for a period, the beta cell cannot compensate by normal secretion, and beta cell dysfunction occur, and even beta cell failure in later stages. While in type 1 diabetes, the problem is mostly in the beta cell. So the beta cells are not secreting enough insulin due to autoimmune damage. So you can see from one side in type 2 diabetes, there is obesity, insulin resistance, and inflammation. But on the other side, the pancreas is not doing good job. There is beta cell dysfunction or even beta cell failure. So this first study was published in Science Translational Medicine in February 2017. And they evaluated the fasting mimicking diet in relation to the markers and risk factors of aging, diabetes, cancer, and cardiovascular disease. They took 100 volunteers and they gave them 3 cycles of fasting mimicking diet. As I mentioned, 5 days of fasting mimicking diet per month for 3 months. And beyond that period, there is no restriction in what they eat. And the whole idea is to see what will change in the market. So let me give you a summary of the results. They found that body weight goes down, not only body weight, but also body composition changed dramatically. Truncal fat went down, total body fat went down. And then another major risk factor, systolic blood pressure is down, and IGF-1 is down. And we'll explain this in a minute. But the most important is there is no serious adverse events were reported. And in the post hoc analysis, when they look to the at-risk cohort, this is a higher risk cohort in comparison to the normal risk cohort, they found much better improvement in body mass index, in blood pressure, in fasting plasma glucose, in IGF-1, in triglycerides, and in total and LDL cholesterol, and the markers of inflammation, CRP. So the study came with a conclusion that 3 cycles of fasting mimicking diet are safe, are visible, and they are effective. But again, larger study is needed, of course, to do a randomized clinical trial. Interestingly, 71 out of the 100 completed the 3 months in a very effective and very safe way. So this slide shows the structure of the study. As I mentioned, 100 volunteers are consented, and they are randomized to be in a controlled diet or a fasting mimicking diet cycles. The control diet group started with 48 subjects and ended up with 32 who completed the control diet, and 16 of them continued to follow the plan for 3 months beyond the intervention period. And in the fasting mimicking diet cycles, started with 52, and the people who completed is around 39 subjects, and 34 of them continued to follow the fasting mimicking diets after the study ended for another 3 months. And see the results here. Body weight went significantly down. Body mass index also significantly down. And then body composition changed. You can see truncal fat, the central fat, the most dangerous fat, went significantly down, and lean body mass went up. It didn't reach the statistical significance, but as you can see, it is up in comparison to the control diet. But the most important you can see here in IGF-1. IGF-1 went down by 21.7, and in the control group, it went up by 8.7. And also you can see systolic blood pressure It went down in the FMD by 4.5 millimeter mercury, while in the control diet, it was just 0.7 lower. So from any aspect, you will see that FMD was much better than control diet. And as I mentioned in the post-hoc analysis, those people with higher risk got the maximum benefit. And you can see people with BMI more than 30 kilogram per meter square has much better reduction in BMI. Again, people with higher GF1 get much better results. People with higher fasting plasma glucose get much better results in comparison to those people with normal fasting plasma glucose. The same with systolic blood pressure, diastolic blood pressure, total cholesterol, LDL, HDL, and C-reactive protein. So whenever you use fasting mimicking diet in higher risk population, you will get much better results. So what happened beyond the 3 months of intervention? And as I mentioned, beyond 3 months, he went back to unrestricted diet. But very interestingly, most of the effect was maintained. So 55% of the effect on systolic blood pressure was maintained for another 3 months. 60% of the change in waist circumference was maintained. 64% of the weight loss was maintained, and 71% of the BMI was also maintained. So it looks like there is a legacy going on. It is not that the effect is just after 3 months, but it can be continued to see some improvement or good improvement for another 3 months beyond the period of intervention. So this again, very interesting information for us. What is also interesting is the compliance and adherence was high. As you can see, among those people randomized to fasting mimicking diet, 71% completed. Only 6 patients or 6 individuals were withdrawn due to non-compliance. What's also interesting and worth mentioning is that any side event from that diet is getting milder and milder over time. So for example, fatigue becomes less and less in the 3rd cycle in comparison to the 2nd cycle and 1st cycle, headache as well, and mild weakness as well. So what is the preclinical trials are telling us in experimental animals for type 1 model where animals received streptozotocin, which kill the beta cell. And you can see in the first panel where the beta cell are secreting insulin in normal way. And then after you give them streptozotocin, you can see mostly glucagon secreting cells, alpha cells are maintained. But when you give streptozotocin and a fasting mimicking diet, you will see regeneration of the beta cell. And you can see in the right hand side graph, the blood glucose went up when you give them streptozotocin. And when you give it in combination with fasting mimicking diet, it goes down. The same in the type 2 animal model. And you can see in the 4th panel, you can see again, when fasting mimicking diet is used, you can see the beta cell are secreting insulin again in normal way and enlarged in the last panel. But again, you can see very, very clearly that after fasting mimicking diet, the blood glucose level went significantly down. And there are several clinical trials going on or have been completed. One study was on the metabolic syndrome with A1C outcome. This is coming very, very soon from Hypertension Institute of Nashville. And there is another study in type 2 diabetes complication, which is still ongoing at the University Hospital in Heidelberg, Germany. And then there are 2 other studies in the treatment of type 2 diabetes and complication in Leiden University Medical Center in Netherlands. So there are several studies, and as I mentioned, there is a lot of attention to the effect of fasting mimicking diet on diabetes. So now let us talk about the effect of fasting mimicking diets on cardiovascular. As you know, in cardiovascular disease, there is a lot of modifiable risk factors. Definitely, there is non-modifiable risk factors like age, like male gender, heredity. But if you look to modifiable risk factors, there are a lot. Smoking, for example, LDL cholesterol, blood pressure, physical inactivity, overweight, diabetes, all those are modifiable risk factors. Again, there are several other modifiable risk factors like stress, alcohol, diet and nutrition, and all of them have been shown to improve significantly the cardiovascular outcomes. Again, going back to the same study in healthy individuals, and looking now for the risk for cardiovascular disease. And again, I remind you, body weight, which is a major risk for cardiovascular disease, is down, significantly down. Body mass index is significantly down. Total body fat and trunk fat, both of them are significantly down. Lean muscle mass went up, but not statistically significant. But you can see it's very clear that body composition is moving in the right direction to reduce the risk for cardiovascular disease. And again, in the post-hoc analysis for the same study in healthy individual, to remind you, there is more improvement you can see for people with a higher risk. So the highest risk of BMI, which is BMI more than 30 in obesity range, there is a significant reduction in BMI. Those people with higher systolic or diastolic blood pressure had much better improvement in their systolic and diastolic blood pressure. The same for triglyceride, total cholesterol, and LDL. Again, as you are higher, you get much better results. Remind you that IGF-1 went significantly down in those people with higher baseline IGF-1, and plasma glucose again went down, and CRP went down. The only thing that went down but didn't change, but I would not say significant difference, is the HDL. So now let us move to another very interesting topic. What is the effect of fasting mimicking diets on autoimmune situations? So what are the autoimmune diseases? This is a failure of the body to distinguish between self from non-self. Some people call it breach of tolerance. And it is the basis of all autoimmune disease. We know so far around 100 autoimmune diseases, among them very common multiple sclerosis, Hashimoto thyroiditis that lead to hypothyroidism, type 1 diabetes, pernicious anemia, vitiligo. Many of those are known as autoimmune diseases to all of us. The basic marker for all of them is inflammation. And you can see that CRP is linked to that inflammation response. So let me give an example of one of the common autoimmune disease, multiple sclerosis. This is a T-cell mediated demyelination and neurodegeneration in the central nervous system, and contribute to oligodendrocyte death and demyelination and axon damage in brain, which eventually lead to neurological damage. What is interesting, in the preclinical trial, fasting mimicking diet was shown to promote regeneration and reduces autoimmunity and multiple sclerosis symptoms. And you can see this in comparison to the normal diet. Regulatory T cells went up and autoimmune T cells went down. So the damage to the nerve axons is much less, and the symptoms of multiple sclerosis is much less. So in experimental animals of multiple sclerosis, you can see that the fasting mimicking diet reduces immune cell infiltration and demyelination in mice. And you can see on the left-hand side in green, the severity score is down to 1, which is major improvement, as you can see. And if you take cross-section in the spinal cord and you look to the upper plates, you will see the filtration of the immune cells on the left-hand side is much less after fasting mimicking diet. And again, you can see the demyelination, which occur in multiple sclerosis, is reduced significantly on the right-hand side. So the damage that occurs in the spinal cord of those animals is much less, and the severity of the disease is much less. So what are the highlights of those preclinical studies and pilot studies? In animal models, there is a reduction in pro-inflammatory cytokines. There is a reduction in autoimmunity due to death of lymphocytes, cell death of lymphocytes. Those are the autoimmune lymphocytes, and increased regeneration of oligodendrocytes, which is very obvious in animal models. And in the clinical trial, in this pilot study, it is very clear that it is safe and visible with a marked improvement in quality of life. But still, a larger clinical trial is needed to prove that those benefits. So now let us move to another autoimmune situation, inflammatory bowel disease, like Crohn's disease, which is inflammation anywhere in the GIT, or ulcerative colitis, which is inflammation in some parts of the GIT, mostly in the colon. And if we look to them, you will find that inflammation again is a major issue, and this is manifested by increase in TNF-alpha, which is a pro-inflammatory cytokines that is very, very common in inflammatory bowel disease. So what is the effect of fasting mimicking diet on the microbiota and intestinal inflammation in the inflammatory bowel disease? And we have studies that have been done in experimental animals and also clinical trials in humans. So if you take the animal and put water fasting, you will see inflammation going down and you see stem cells are going up. But if you give them fasting mimicking diet, not only inflammation is going down, but also there is a reversal of intestinal shortening. And not only stem cells are going up and regenerative effect of the stem cells are going up, but you see also protective microbiota is going up. So in clinical trial, they took 61 individual with CRP more than 1 milligram per liter, and they put them into 3 cycles of fasting mimicking diet. And what they found? Reduction in leukocytes and also reduction in systemic inflammation as manifested by reduction in CRP. So what is the effect on microbiota? If you take the animal model of colitis, DSS, and you give them a fasting mimicking diet, as you can see in panel 3, you will see significant change in 2 strains of bacteria. The first is the lactobacillus, which is responsible for the T cell activity, which improves significantly the GIT symptoms. And also in the bifidobacteria, which is also very important. You can see it in maroon color here. It went significantly up, which reduced significantly the symptoms in the animal model. So what is the highlights of the preclinical and clinical trials that have been done so far in the inflammatory bowel disease? There is a partial reversal of the inflammatory bowel disease in comparison to water fasting. There is a reduction in the marker associated with intestinal inflammation and immune function. And there is also increase in the intestinal regeneration markers. So this is manifested as well by promotion of the lactobacillus colony and bifidobacterial colony, which help significantly in reducing the symptoms of the inflammatory bowel disease. In the clinical trials, there is a potential reduction in inflammation and leukocytosis in humans. So again, bigger studies are still needed. Now let us talk about fasting mimicking diets and neuroscience. So let us talk about the effects of fasting on neurocognition. So what usually happens in the body when you put the body in fasting situation. First, the liver get depleted from the glycogen storage, so there will be increase in fatty acid oxidation and production of ketones. The most important is that ketones is what we call it now super fuel. They are transported into brain and induce expression of what's called brain-derived neurotrophic factor. Brain-derived neurotrophic factor. These are very, very important because brain-derived neurotrophic factors promote synaptic plasticity, improve the cell stress resistance, and also enhance cognition and motor performance. So in experimental animals that have been done in murine models, they found that fasting protects neurons against degeneration, which is usually seen after stroke or after trauma. And also it leads to slow progression of some major problem like Alzheimer's disease or Parkinson's disease. So this is, again, a very important aspect of fasting and its impact on cognition. So this is a very interesting study that was done by Brandhorst and his colleagues and published in Cell Metabolism in 2015, examining the effect of fasting mimicking diet on motor coordination, hippocampal dependent learning, and short and long term memory. And what you can see in the left-hand side, when the experimental animals are exposed to fasting mimicking diet, the time that they spend on rotarod is longer, which indicates much improvement in coordination and motor function. And also their cognition is improved significantly, and the memory have been improved significantly. You can see it in the Y maze, and also marked improvement in recognition index, which is all in sum is indicating that the success rate of fasting mimicking diet in improvement of mini neurocognition is nicely documented in experimental animals. Now there are 2 clinical trials going on right now in neuroscience. One of them is a randomized phase 1/2 study examining the effect of fasting mimicking diet in patients with cognitive impairment. The study is done going on in Geneva, Italy. And there is another study which is also in Italy, which is evaluating the effect of fasting mimicking diet added to functional therapy for treatment of depression. So you can see there is a lot of interest right now in fasting mimicking diet in clinical trials. Now let us move to the most exciting data. This about the effect of fasting mimicking diets on cancer. So as you all know, cancer is a result of abnormal mutation and proliferation of cells. And the cancer cells are the most metabolically active and rapidly dividing cells in the body. So it needs energy all the time. It needs glucose and need nutrients all the time. And the high IGF-1 and insulin level are correlated with the cancer risk and poor prognosis. That's why when we show you that IGF-1 going down, that's actually a benefit that you can see in those patients in clinical trials. So fasting mimicking diet creates a hormonal and metabolic environment that helps reduce the level of factors involved in cancer growth and support the ability of the normal cells to resist stress and survive in a much better way. So this is had been always an assumption that fasting mimicking diet will have an impact, a great impact on cancer. So now let us see the differential stress response of normal cells in comparison to cancer cells. Let me start first with normal cells. Normal cells has normal growth, normal adaptation, and normal response to stress. Now, if you lower IGF-1 and insulin by fasting mimicking diet, the cell will have a much better activation of the stress-resistant pathway and inhibition of the nutrient sensing pathway. So in that scenario, the cell is more protected. There is decrease in DNA damage and increased tolerance to chemotherapy. Now, in cancer cells are in accelerated growth, as you all know. There is poor adaptation and poor response to stress. So when you give them fasting mimicking diet and you lower IGF-1 and you lower insulin, the cell will continue to grow, but there is no adaptation to fasting and no protection from stress. Now, if you take that cell and you expose that cell to chemotherapy, you will have increase in DNA damage and increase in chemotherapy efficacy. So this is very, very important because when you do fasting mimicking diet, you are helping treatment of cancer cells. So in preclinical trial, it was shown that when you expose the cells to fasting mimicking diet, it will start to increase HO1, which is responsible for activation of the T cell mediated cytotoxicity, which is very, very important in treatment of cancer. But in the same time, it protected the cells from the oxidative stress and the cytotoxicity of the chemotherapy. So those are all beneficial in treatment of cancer. So this is another important preclinical trial where if you have mutated cancer cells and you expose them to fasting mimicking diet or fasting mimicking diet in combination with vitamin C or the triple combination between the two and the chemotherapy, you will see marked reduction in the growth of the tumor cells and also reduction in the tumor size and much better survival. And you can see this in day 33 and day 36. You can see the tumor size is much less. And it's very interesting that a combination of the three lead to improvement in the survival rate. So this again is giving signal that using fasting mimicking diet with chemotherapy and with vitamin C can be very helpful, at least now in experimental animals. So it is very important to know the relationship between protein restriction and cancer. And as you may notice in the graph on the left-hand side, every time that we go up on protein in people between the age of 50 and 65 or above 66, you will see significant increase in IGF-1. And as you know, IGF-1 is the insulin-like growth factor 1, which promote tissue growth and cancer growth. So if you look to the table on the right-hand side, you will see very strong relationship between the amount of or the concentration of IGF-1 and the relative risk of cancer. And you can see in cancer breast, when the IGF-1 is high, you see the relative risk is 4.5, and even after adjustment, you will see it significantly high. The same, you can see it in men in prostate cancer. And again, a higher level of IGF-1 is related to increase in the relative risk of cancer. So restriction of protein and reduction of IGF-1 or using fasting mimicking diet, which reduce insulin like growth factor 1, IGF-1, and insulin has a tremendous effect on the cancer growth. Here is another study which is looking to the short-term fasting, water fasting for 48 hours on the tolerance to the neoadjuvant chemotherapy in HER2 negative breast cancer patients. And you can see very clearly cycle over cycle that there is an increase in erythrocytes and increase in thrombocytes. Again, is telling us that short-term fasting is very effective in that scenario. So I would like to tell you that fasting mimicking diet is attracting the appetite of cancer researchers to see what is the real impact of fasting mimicking diet. As I showed in pilot studies in experimental animals, there is a lot of exciting data. And you can see on the screen a lot of studies that are still going, or some of them have been completed, but they are studied in many kinds of cancer, especially breast cancer and prostate cancer and some hematologic and solid cancers. So what is the emerging areas of research about fasting mimicking diet? It is now obvious that fasting mimicking diet reduce oxidative stress, reduce inflammation, and there are several mechanisms to explain that. One mechanism is that reduction in energy intake and weight loss reduce the cellular oxygen free radical production, and by that way reduce the oxidative stress. The other way around is increase antioxidant effect. So when you have a nutrition depletion stress, there is upregulation of the antioxidant system and increased disease resistance. So this potential mechanism is now going to be studied in asthma and in rheumatoid arthritis and some other autoimmune diseases. But interestingly, any disease that inflammation and cytokines play major role in that disease may be affected by fasting and by the use of fasting mimicking diet, which we are excited about it and waiting to see it in clinical trials. Another area of interest is the impact of fasting mimicking diet on surgery, on ischemic tissue injury. Especially it has application in preoperative elective surgery. Can you improve by dietary restriction the outcomes? We know that inflammation and oxidative stress cause hyperactivation of central nervous system and vasoconstriction. Of course, when vasoconstriction occurs, there is hypoperfusion and maybe atherosclerotic plaque rupture. While when you have fasting, you have mild stressor, which we call it hormesis, and this leads to stress response, increase in stress response genes. This is very important, and we think seriously that maybe fasting mimicking diet with certain dietary restriction in some way may have some very good effect on ischemic tissue and on also elective surgery. But the most important and most interesting that we know for years there is a relationship between nutrient intake and wound healing. And if we know that fact and that some nutrient can affect wound healing in positive way or negative way, will dietary restriction, will fasting mimicking diet has an impact on acceleration of wound healing and can be of value in elective surgery or not. I think we need a lot of clinical trials in the future to answer these very important questions. So if you quickly get a glimpse of the clinical trials that have been completed or ongoing or planned, you will find it covers different aspects of common medical problems, including cancer, metabolic syndrome, depression, diabetes, obesity, liver fat, hepatosteatosis, brown fat. There is a lot is going on in that field right now. So how to compare FMD to other eating patterns? Yeah, people can go for calorie restriction, or they can go for intermittent fasting or periodic fasting or fasting mimicking diets. All of them will cause weight loss, which is fine. We know that. But interestingly, if you look to the body composition, you'll find that fasting mimicking diet is the only one that maintained the lean body mass. Again, periodic fasting and fasting mimicking diet induce the cell rejuvenation. This is proven in the lab.
And at least it will provide food in that way.
So let me end up by asking a very important question. How does fasting mimicking diet potentially affect so many body systems? We know that fasting affects every cell. Fasting affects every organ system in your body. So when you put the body under the stress of food deprivation, you trigger
self-preservation mechanisms. So, I'm sorry.
So let me end up by asking a very important question. How does fasting mimicking diet potentially affect so many body systems? We know that fasting affects every cell. Fasting affects every organ system in your body. So when you put the body under the stress of food deprivation, you trigger self-preservation mechanism. By the way, in many species, this is conserved because food scarcity is a norm. But in human being, when you are hungry, you go and eat, and you supply your body with a lot of nutrients. You stimulate insulin secretion, you stimulate IGF-1, you stimulate growth of tissue. And this is the situation that we are trying now to see if we can cause some restriction or prolonged restriction or timed restriction or cyclic restriction in the form of fasting mimicking diet, how this will affect different organs and different diseases as well. Still, we don't know exactly what is the degree of dietary or caloric restriction that may affect the downstream diseases. Maybe metabolic is different than autoimmune, than cancer. How many cycles is needed and for how long? I think there is a lot of science is evolving in that area. And as I mentioned, a lot of researchers has a very strong appetite for research in the area of fasting mimicking diet. You are opening that box of a lot of new information. And I hope in the future this will lead to a new discovery in that area. I would just like to remind you at the end that fasting mimicking diet is currently not approved for treatment or cure of any disease. Further clinical trials and further clinical development is still needed. But we are in the beginning of a new era in understanding of how fasting mimicking diet and fasting will have an impact on many of the metabolic and autoimmune and neuro and inflammatory bowel and cancer. So stay tuned and thank you so much.
Thank you very much, Professor Osama, for this very nice and exciting mood of food, which is fasting mimicking diet. And I'm sure that we will have many questions about this style and other styles in nutrition. I'd like to leave the mic to Professor Refaat Hegazi to start the comments and discussion. Dr. Refaat.
Thank you so much. Thank you so much, Dr. Osama. Very exciting. And it's amazing how we evolve as a nutrition field, the many concepts and how we test it from the idea all the way to the clinical trial phase. I believe that this is a wealth of information, and it goes along with the obesity pandemic that we all face and how to address it. We know that fat deposition is not good news for any of us because it starts a subclinical inflammation method, by which actually patients get a continuous secretion of cytokines while they don't even feel it. And those cytokines secreted by the fat cells, they affect the pancreatic function, they affect the muscle function, they affect even the immunological functions. So I think I will start with one question on the fasting mimicking diet. What do you think of in patients with malnutrition or sarcopenia, and specifically sarcopenic obesity? Would this be a good option for them, or maybe we have to be careful, or what is the guardrails around this?
Yeah, that's actually a very good question. I would just would like to tell from, at the beginning that I was recorded this session just yesterday for Harvard Medical School. So I thought to play that part that was recorded. So you will see it. It was part is live and part is recorded, and rest me a little bit to have a very good discussion. So sarcopenic obesity is a major issue, especially in elderly population. Dr. Refaat, as you know, people beyond the age 40, they start to lose muscle mass. And they lose muscle mass progressively every year from, I would say, around 350 to 450 grams of muscle mass is lost every year. And that loss can be higher in people with uncontrolled diabetes, as you all know. Also, people who are bedridden in the hospital for longer duration, they lose also muscle mass. And to compensate that muscle mass, you need actually the opposite. You need to give more protein. And also for healthy population, you need to do more strength exercise to maintain muscle mass. But this is a whole different animal. What we are talking here about is how I can, for a short period of time, only 5 days, I will inhibit the nutrient sensing in your body to just give the body the impression of fasting. And by the way, in giving them enough amino acids, but no more than 10-15% of protein, you are not, the whole idea is not to stimulate IGF-1 during that period. And this is now tested in a very efficient way in many aspects, in preclinical and clinical, and it was very, very effective. But it is not designed for treatment of sarcopenic obesity or for someone who is bedridden in the hospital. This is mostly for chronic diseases and cancer and autoimmune diseases. And as you can see, those are just 3 cycles, 5 days of fasting every month for only 3 months. There is studies going on now to see what is the impact if you do it every month for a whole year. But between intermittent fasting and fasting mimicking diet, you'll find some way that you can put the body under enough stress to cause apoptosis of some of the dysfunctional cells and rejuvenation of newer cells.
Absolutely. I totally agree with the whole idea of physiological stress. And I think it goes a long way. Whether physiological stress can result from fasting or fasting mimicking diet, or it could be resulting from an exercise. It just, we have to expose the body to some sort of physiological stress in order for the cytoprotective enzymes to start secreting, and that's actually modulate anti-inflammatory effect, which antagonizes the pro-inflammatory diet-inducing effect. So I totally agree with you, Dr. Osama. This is probably not for specific patients who have sarcopenia or sarcopenic obesity, but this is a great tool if somebody would like to change diet and change lifestyle in a way that could get the benefit without medications. And this is very important too. This is a very diet. It's not pharmaceutical, right?
Yes. But I would like just to comment, because you mentioned exercise. Definitely exercise has a lot of benefit. But whether exercise put the body under enough stress and have an anti-inflammatory effect all the way is actually a question mark. Because what you will see in the moderate intensity exercise, inflammatory cytokines are going down and inflammation is going down. But if you exceed a little bit and you go in the direction of strenuous exercise, actually inflammatory cytokines goes up. There was one study which was done among marathon runners by the end of marathon and measured their inflammatory cytokines, and it was actually 20-30 times higher after extreme stress that occurs by exercise. So putting the body under stress by fasting is better. And in reality, if we go back in history and we hear about people or prophets who survived for 120 years or 200 years or 300 years, and you just imagine what they used to eat at that time. They were hunters, and they would only eat when food is available. So there was a scarce of food, and that scarce of food put them under significant stress. So they have much better active cells all the time. Longevity Institute in University of California are doing a lot of studies right now to see how you can prolong the life of the cell in human, not just in experimental animal, by putting the cell under certain stress. You can shed all the old cells, all dysfunction cells, and rejuvenate the newer cells with active mitochondria.
There is very interesting new research, Dr. Osama, about stimulating the muscle, inducing two key cytokines in the process of fat metabolism and GLP-1 and insulin secretion. And those are IL-6 and IL-15. What we know that now, if we stimulate muscle protein synthesis, they actually secrete two cytokines, which they stimulate insulin secretion, and also they stimulate fat, getting the white fat into brown fat, as a conversion to the healthier fat. So I totally agree with you. It's not a lot of stress, but a little moderate stimulation of muscle is probably better than none.
Yeah, sure. Combine them. I remember when we were young, we used to, during fast Ramadan, to play football or do some exercises. And I think it was very interesting that when you are exercising while you are fasting, it can have a double benefit.
True. I want to open the floor to our colleagues also for questions.
Okay, I would like to add a point here because Professor Hegazi mentioned lifestyle modification. There was a very nice meta-analysis published on the end of August, just a couple of days ago. It stimulated me just to highlight it on English and Arabic, English for doctors and Arabic for all people, that lifestyle modification, when it starts earlier, it can prevent diseases. So chronic kidney disease can be prevented, and this is a primary prevention. And the primary prevention style was changing food, increasing the style of fruits and vegetables, increasing potassium content, and doing exercise, moderating salt, and stopping smoking. And this was, yes, all the studies published in this meta-analysis were observational studies, but give numerical values. Exercise itself reduces chronic kidney disease as primary preventive tool by 18%. Vegetables and potassium, both of them reduced by 20 or 21% as shown in this meta-analysis. So it's better to start all these lifestyles before chronic diseases, because as Professor Hegazi mentioned, sarcopenic, and sarcopenic even in nephrology is very bad, and maybe the end of the spectrum. If the muscle is lost, I think it's very difficult to rebuild it again. So it is wise to start earlier. The last point about fasting and the kidney, there is a very nice experimental study published by Japanese about sodium glucose cotransporter 2 inhibitors and the kidney to prove the beneficial effects of sodium glucose cotransporter 2 inhibitors. And when I read it in details, I found the control, which is fasting animals. The fasting improves kidney disease by many mechanisms, even exceeding the benefits of sodium glucose cotransporter 2 inhibitors. So this is time to enhance all these lifestyles in healthy persons to get the benefit. I think it will be to prevent diseases. But as Professor Osama mentioned, we are waiting further evidence from clinical trials, but the hypothesis is very stimulating and illuminating. I'd like to leave the discussion. Yes.
So Dr. Hussein, would you mind to give me the pointer again?
Yes.
If you don't mind. I would like to just show something which is also very interesting.
Yes, please.
Which is from our latest research. So, okay. So this is a study which I just mentioned about lifestyle intervention for 10 years, follow-up for 10 years. And as you can see, people maintained weight loss for very, very long time, around 6.9% weight loss and maintained weight loss. But here is the most interesting. This is the effect of lifestyle intervention on the kidney. And you can see people who maintain the weight loss has less chance to develop diabetic nephropathy. So again, this is a very interesting observation. This over 10 years. And not only that, we started to see improvement in GFR and reduction in creatinine level. It is on publication right now. So you will see it soon. And this is the longest ever lifestyle intervention in real world clinical practice. We used to say that when people develop chronic kidney disease, it is downturn from that time. But reality lifestyle is the only thing that can reverse that course of chronic kidney disease. Improvement in GFR and reduction, as you can see here, prevention of microvascular complications in the form of diabetic nephropathy.
Okay, thank you very much, Professor Osama, for this point, and we are eager to read it in details when it will be published. I think it will be soon. We have Professor Amr Al-Husseini. Prof. Amr. You are welcome. You are welcome, Dr. Amr.
Thank you, thank you. Dr. Osama, I really enjoyed your lecture. It's fascinating as usual. As Dr. Hegazi mentioned the sarcopenia, and Dr. Hussein, I also want to comment on the osteosarcopenia, because usually when we start to lose muscle, we start also to lose bone. So muscle loss and bone loss usually goes hand by hand. So I just have a comment and a question. So the first is a comment. Most of the study that I'm sorry again, I didn't attend the whole lecture, and I'm also attended through my cell phone. But if I remember correctly, and if this is right, most of the studies, they didn't really have a real endpoint with mortality or cardiovascular disease, or major outcome, cardiovascular outcome, or stroke, or renal end-stage kidney disease, or progression of kidney function, but rather was using surrogate endpoints with biomarkers. I don't know if you have really a real endpoint instead of surrogate endpoints with the biomarkers. I really like to see improvement of patient survival, or a decrease of cardiovascular disease, or the slowdown progression of kidney disease, or something like that. Then my question for you is, do you think this fasting mimicking diets can help also with the bone loss? I remember you said by the end of your slides that this can affect any organ, and hopefully this can help most of our organ system. Do you think this would be also helpful for our metabolic bone disease, especially in our CKD patient, the chronic kidney disease patient? And thank you so much.
Yeah, Dr. Amr, these are all wonderful comments and very good questions. Definitely the fate of the fat cell and bone cell are going hand in hand, because you have them coming from the same dormant cells or stem cells. And that's why when you give a drug like TZD and you stimulate proliferation, PPR gamma, and stimulate proliferation of new fat cells, bone cells get affected and people get fractures. So both of them are going definitely hand in hand. Regarding the whole outcome in the points, mind that fasting mimicking diet and fasting research is very new. To know what is the impact on longevity and the impact of chronic diseases on long term, you need a lot of time. You need 6 years, 7 years, 8 years, and you do it in even older age and you see the results. But what we have right now is a study that had been done on experimental animals. And experimental animals, it showed double or triple longevity. So double or triple longevity is very interesting. So the lifespan of the animal is much shorter. So you can get some information or some indication. But as I mentioned, this is a whole new science, and we will hear in the future a lot. There are some studies were designed in many centers now looking for the effect over 10, 15 years. But those studies up till now just in the first year or second year or even third year. But I hope in the future what we see in experimental animals can be replicated in human. Regarding the effect on bone cells and chronic kidney disease, you know, up till now we don't have too much research, but if you think that one part of chronic kidney disease etiology or pathophysiology is inflammation, as we believe in diabetes, inflammation goes significantly down. And all markers of inflammation go significantly down. And CRP, high sensitivity CRP is significantly down. So any chronic kidney disease that is rooted in inflammation or in autoimmunity, I think they may get some benefit. Reversing the clock is always very difficult, but there is many signals now to show that by fasting or fasting mimicking diet or intermittent fasting, maybe you can get much healthier cells and you can reverse the clock in some people.
Okay, thank you very much, Professor Amr. Professor Abuelmagd, I hope that the mic is working now. For Megahed. I don't know why the technology is not working with Dr. Megahed, but
yeah.
Yes, okay. Yes.
Oh, we can hear you now.
Yes, yes. We can see and hear you now.
I have a comment and a question.
Please.
Yes. My comment on the prophetic diet, fasting was a regular part of the messenger's life, peace be upon him. He would fast every Monday and Thursday, and he also fast the 13th, 14th, and 15th of each lunar month. And above this, our messenger, peace be upon him, was not fasting. If he was not fasting, he was on intermittent fasting. I think Prophet Muhammad eating only once a day, one meal per day, and I see many papers about the prophetic diet, which stimulate the fasting diet, explained nicely by Professor Osama. And in Arabic, عادة النبي صلى الله عليه وسلم ليس في السنة تقسيم الوجبات الثلاث لفطور وغذاء وعشاء، بل لم يكن من عادته صلى الله عليه وسلم تناول أكثر من وجبتين في اليوم والليلة التي لا يصوم فيها. عن عائشة، وهذا الحديث في البخاري ورقم 6455، يقول: ما أكل آل محمد صلى الله عليه وسلم أكلتين في يوم إلا إحداهما تمر. يعلق الحافظ ابن حجر في فتح الباري في الجزء 11 في صفحة 292، يقول فيه إشارة إلى أنهم ربما لم يجدوا في اليوم إلا أكلة واحدة، يعني معظم حياة الرسول كان اليوم أكلة واحدة، فإن وجدوا أكلتين يعني إن يوم كلوا مرتين يكون إحداهما تمر. انتهى كلام ابن حجر في فتح الباري. فأنا يعني قلتها بالعربي وبالإنجليزي. My question to Professor Osama, can we divert our attention as a diabetologist from concentration on A1C to concentrate on the body weight?
Okay. First, Dr. Megahed, your comment is very, very important. And prophets in general had been practicing fasting and recommending fasting in different formats. Definitely, Prophet Muhammad sallallahu alaihi wasallam was among the best in applying fasting in a very constructive way. And you may remember الحديث صوموا تصحوا. And we never know how صوموا تصحوا. يعني we think that eating you'll be better, but fasting to be healthier is extremely difficult for the mindset to accept. ما ملأ ابن آدم وعاء شر من بطنه. That's again is exactly the same scenario. So definitely fasting, whether it is 2 days per week, 3 days per month, 5 days consecutive, but put your body under a very, very good stress. You don't need to fast and replenish and eat a lot. That's what we usually do in Ramadan. You fast for 16 hours, you put your body under stress, and then you replenish, and then all the effect of the fasting is gone. So you need to put yourself, like Prophet Muhammad, under extreme fasting. So if you put yourself under extreme fasting, and you do it even 2 days per month, you don't have to do it 2 days per week, even 2 days per month. If you put your body under extreme stress for a whole 24 hours, that's what can rejuvenate your body and rejuvenate the cells. And this is back to what you said about eating only tamr. When the Prophet was saying يكفي ابن آدم لقيمات يكن صلبا. So you eat little, or نحن لا قوم لا نأكل حتى نجوع وإذا أكلنا لا نشبع. All of those are concentrating with the whole concept that you eat very, very little. So you will be like the 5-2 fasting, or you will be in the extreme form if you can be able to do it. The second point, which is back to your question, and I personally believe that this is the new concept, and we have to move in that concept. And I claimed that concept almost 20 years ago in the American Diabetes Association in a plenary session, and I mentioned that we are treating diabetes in the wrong way. We are just medication concentric. If we go back to the nutrition concept, if we go back and try to focus on body weight, our data 20 years ago showed that when people lose just 7% of their body weight, insulin sensitivity goes up by 57%. People who repeated this, they found even 70 or 80% improvement in insulin sensitivity. So if you have someone who's type 2, which is the major problem is insulin resistance, focus on body weight and causing efficient weight loss, you can actually reverse diabetes. In Y-Weight program, we had seen and we published 21% remission, complete or partial, or major improvement just by weight loss. Many of the medication that we are using right now, like GLP-1 analogs, SGLT2 inhibitors, big part of their effect is because of weight loss. And we found in one study, which was observational study done over 2.5 years of using GLP-1, that only people that get the maximum benefit are people who lost weight. And people who didn't lose weight, they didn't get that much benefit. So in reality, switching the entire target to be on body weight rather than on A1C, I think it is a very good idea. Cost-wise, it is less cost. Medication-wise, less medication. We showed in Y-Weight program 21% to stop the insulin, and majority cut their medication down by 50 to 60%. Cardiovascular disease will be definitely better, because if you just focus on A1C, you just reduce A1C. But when you have lifestyle intervention and weight management, you have triglyceride down, HDL up, LDL down, blood pressure down, microalbumin down. You have a lot of other additional benefits. And then above all, what is the quality of life? Quality of life of people who are on lifestyle and weight management is way better than if you are on 4 or 5 medication. And the problem is that it became like a spiral. You start with medication and you add another one and third one and fourth one, and you add insulin and more insulin and more insulin, and you'll be in 300 units of insulin and 1,000 units of insulin and so on. I think the way that we are treating diabetes right now is absolutely a problem. especially in the first 4 or 5 years. 4 or 5 years or 7 years, the chance to reverse diabetes is significantly high if the focus is all about weight management. Even in the diabetes prevention program, we found that even 3% weight loss can prevent diabetes. It is not like you have to reach significant amount of weight loss, 3% weight loss. What fasting does, which is very beneficial, it depletes the liver from glycogen and over time from fat. And this is, again, very, very important that you need to do. That's why when people go for bariatric surgery, immediately after they go to bariatric surgery, they see a very good response. What they found is that intrahepatic fat goes significantly down. So very low calorie diet, very low carbohydrate diet, intermittent fasting, prolonged fasting, bariatric surgery, any part of those that will improve accumulation of fat, especially in the visceral area and intrahepatic area, and reduce inflammation, as Dr. Hegazi mentioned, it is more beneficial.
If you allow me, we have Professor Rashid Barsoum. Since 3 years, he visited our center, and he mentioned elegantly autophagy. So he explained autophagy and its machinery, how to control, and one of the merits of fasting is to enhance autophagy. And he mentioned a very nice story when he was asked from the church why we should fast. His answer was, because this is the order of Allah to fast, so we should follow. But after working and reading in details in the autophagy, he found the reason, and one of the reasons and the benefits of fasting is enhancing autophagy and reducing and improving the machinery inside every cell. Regarding the very low calorie diet that Professor Osama just mentioned, I have a concern about very low carb diet in chronic kidney disease. I'm not believing in very low carb diet, although I know that high carb density is associated with progression of chronic kidney disease. But in chronic kidney disease, I don't recommend at all very low carb diet. I would like to hear from you, Professor Osama, about this point. Am I right or wrong? And what is the concept?
Oh, yeah, that's actually a very, very good question. And people usually ask, and I see some people are asking also about keto diet and chronic kidney disease and so on. Let me just explain this in a very, very good way. The diet that put the foundation of all that concept is called the Michigan diet and was developed in 1920. But the whole concept of Michigan diet or or low carbohydrate diet is not to lower carbohydrates. People misunderstood it, and in the 70s it had been nearly biased concept entirely, or deviated concept entirely. What people used to do in 1920, 1921, 22, and those years, they used to give you the exact amount of carbohydrates that your body needs. It is not lower carbohydrates. It is the exact amount of carbohydrates that doesn't deviate your metabolism. And they used to do a test, which I just explained at the beginning, called the carbohydrate tolerance test. It is a very sophisticated test. They admit people to the hospital, and they gradually increase carbohydrates from 0 up to 250 grams. And every day they measure carbon dioxide production, ketone production, they measure blood glucose, urine glucose, they measure all electrolytes in a very sophisticated way. And when they see deviation occurs, then they say, this is the amount of carbohydrates that your body can tolerate without altering metabolism. And then they give you the rest as fat and as protein. But over time, because of the gap of years, when people started to reincarnate this diet in the late 70s, and they call it the ketogenic diet, they didn't go with what exactly the amount of carbohydrates. They said, okay, cut carbohydrates down to around 20 to 30 grams. Now, if you cut carbohydrate down to 20, 30 grams, you initiate two processes in your body, ketogenic process and gluconeogenesis. So ketogenic process is fine because, as I mentioned, ketones has a better effect than glucose, especially on the brain. Fat will go down and people will lose weight. That's fine. From that aspect, it is fine. But the major aspect, and the blood glucose will be definitely a benefit because you're cutting carbohydrates down. Definitely, anytime you cut carbohydrates down, blood glucose will down. But here is a major problem. The major problem is that you are stimulating gluconeogenesis. So protein in your body will go significantly down. So every time you do ketogenic diet, you lose weight, but you lose muscle mass. If you gain the fat mass can go quickly up back. You know, if you stop the diet, you gain the fat back. But muscle mass, you will never get back. Bone mass will be affected significantly. Those you cannot get them back because you build all your muscles over years by growth hormones, sex hormones, and insulin. And in elderly or adulthood, all those hormones are significantly down. So this is one major problem. The second major problem is that you cannot continue to do it for a very, very long time. That's very, very difficult. And people cannot do it for prolonged time. Studies at Tufts Medical School found that by the end of the entire year, the average weight loss is around 3 pounds, like 1.5 kilograms, because people cannot maintain it beyond certain period of time, because this is a radical change in the life pattern. And then the third problem is that once you do this, you have a significant water shift in your body. This gives false impression at the beginning of big weight loss. It's actually water shift. And every time you do this, you have a water shift in your body. But there's many side events that can occur, like bad breath, like severe constipation, and so on. What we are suggesting now, and it works exactly with the same benefit, is if you cut carbohydrates lower than 40%, and actually increase protein, as I mentioned in the structural nutrition plan, increase protein to 1 to 1.5, and ask people to do strength exercise. You maintain their muscle mass, you maintain their energy expenditure at very high level, you maintain their basal metabolic rate in a very efficient way, and you maintain weight loss. And the benefit of doing it is actually tremendous. But in Egypt, for example, this is not the style of eating. People are carbohydrate concentric. They eat significant amount of highly processed carbohydrates, bread and rice and cakes and others, and then sugar, significant amount of sugar and significant amount of starch. So this is a major issue for obesity, for chronic kidney disease, for hypertension, and for diabetes. So changing dietary pattern in Egypt should be a national effort that needs to be done.
I agree with you 100%, Dr. Osama, about this point. We should moderate a carbohydrate, but to eat without carb or very low level of carb, I think it's harmful, and should be, especially in patients with chronic kidney disease, because in chronic kidney disease, the machinery of acidosis is working. So if I stimulate ketogenesis more and more by very low carbohydrate, I think this will be followed by tremendous and bad consequences.
Yeah, putting people in general in acidemia by severe acidemia. I mean, if someone has chronic kidney disease, or someone is drinking alcohol, someone is doing very severe fasting, or cutting the carbohydrates down significantly down for very long duration, and they are prone to acidemia, it can be a problem because not only potassium will go significantly down in that scenario, but there is prolongation of QT interval, and people can get arrhythmia and sudden death. So for people with chronic kidney disease, this is not something that you recommend or even think of. So I totally agree with you about that concept. And just moderating carbohydrates would be fine.
Yes, I advise my patients with early stages of chronic kidney disease is to reduce carbohydrate little bit, because I don't like the high carb density. So of the carbohydrate constitute more than 70% of calories. This is very bad. but I think from 50 to 70%, it is moderate restriction to the style that you know in Egypt. So this is why I advise for moderation of carbohydrate rather than very low carb diet.
Yeah, but the type of carbohydrates, Dr. Hussein, type of carbohydrates is very important. You know,
starch, complex,
sugar, starch, and white flour should be reduced significantly. You know, carbohydrates from legumes, from fruits, from vegetables, from dairy, I have no problem with them. And mind that your brain needs 130 grams of carbohydrates per day. So for your brain to function, it needs 130 grams of carbohydrates. So cutting carbohydrates to lower than 130 grams, you are devoiding your brain from big source of energy.
There is a very nice report in the Lancet, a very nice article about the quality of starch, quality of carbohydrate. The quality of carbohydrate, complex carbohydrate, including a big amount of fibers. This is the welcomed carb. But refined, like sugars, rice, bread, all these are very bad.
You're absolutely
Dr. Said Khamis? Dr. Said, Professor Said Khamis?
Yes, Professor Hussein. Thanks
for
this elegant presentation. Just my question is regarding the fasting, prolonged or intermittent or whatever. As we know that there is nothing in life is 100% ideal. What is the bad or side effect of or adverse effect of fasting in the whole body organs, especially if there is a comorbidity like CKD or whatever? So fasting is always okay, but we should be careful when we apply fasting. Thank you so much.
Oh yeah, thank you, Dr. Said. You know, we have to differentiate between two concepts. Total fasting, which include food and beverages and water, is different from what I'm talking about. What I'm talking about is about food only. People should actually drink more water during fasting. If you are fasting and you need the benefit, you need to drink a significant amount of fluids. Depriving the kidney definitely from fluids and water will be a problem. But doing the typical fasting or intermittent fasting will be fine. That's the point.
And for patients with advanced CKD and dialysis patients, I advise them against fasting, even for food. Yeah.
You know, Ramadan is a different scenario. If you are talking about Ramadan, it is not suitable for them to fast. That's for sure. Yeah, but, not suitable for them. But if we are talking about fasting, just fasting food and taking fluids, we don't have any data right now in chronic kidney disease. So I cannot say anything about it because we don't have that.
So I advise them against fasting, but I encourage them and advocate exercise, as Dr. Refaat just mentioned, because exercise, even on dialysis, improves a lot of parameters of anemia, physical well-being, etc.
Absolutely.
Professor Sahir Al-Khashab.
Thank you.
Thank you, Dr. Said.
Thank you, Dr. Osama, for this very nice lecture. Thank you, Dr. Hussein. I would just like to add just a small comment. I was convinced exactly like Dr. Hussein and like Dr. Osama that the keto diet is the keto diet that, like it is described to people, is rather harmful than useful because people do. Out of experience, I have, actually they're not my patients because I do advise against the keto diet concept, but I have lots of friends, and this is what's perplexing me, who got on the keto diet and they lost lots of weight and they became insulin independent, one drug dependent instead of 4 drug dependent. So actually this keto diet might have some benefits, but it needs only modification. And also I think what lacks in the literature is that the long-term studies about the effect of the high-fat diet, because this is part of the keto diet, that they don't only lower their carb or cut their carb but they eat tremendous amounts of fats. So what do you think about that, Dr. Osama? يعني this increased amount of fats regarding the metabolism. They eat like really lots of, they leak like 500 grams of butter per day. What do you think of that? But
Okay.
they do lose weight and they become diabetic free.
Yeah, okay. So you raised a lot of very good points about the impact of keto diet, but I have to differentiate between two things: between commercial, non-science ketogenic diet and medical and science ketogenic diet. When we implement any ketogenic diet, we raise protein up and give healthy fat. If you raise protein up and give healthy fat, you get the maximum benefit. But if you just go like those commercial stuff and just eat butter and eat there and here and all kind of fat, and LDL will go significantly up, 20–30% up. And maybe on the long term, there will be some definitely drawbacks from that scenario. But if you lower carbohydrates down and lower glycemic index down, diabetes will definitely improve immediately and significantly. People will lose significant amount of weight. But what they need is to give them more protein and then make your fat from monounsaturated fat, polyunsaturated fat. And if you give saturated fat, it has to be only from dairy source. We just finished a study looking for high-fat dairy and low-fat dairy, and there is no impact, no drawbacks of high-fat dairy. And actually, high-fat dairy is beneficial to some extent. So giving saturated fat from dairy, monounsaturated fat like olive oil, canola oil, avocado, and nuts, and so on, polyunsaturated fat, omega-3, fatty fish, all of those are fine. And give enough amount of protein because you need to stop gluconeogenesis and maintain muscle mass. This is now a better ketogenic diet and more efficient ketogenic diet and can have a very good impact. But when you lower carbohydrates, what we usually tell people, we don't tell them go to 20 grams or 30 grams because we are not doing any carbohydrate tolerance test. What we usually say, lower carbohydrates to a way that you can tolerate, to the lowest that you can tolerate, without giving them a specific number. But we say that 3 types of carbohydrate should be stopped or reduced significantly: sugar, white flour, and any product from white flour, and then starchy food like potato, rice and corn, and banana, for example. Those are starchy food. If you eliminate those entirely, and then you eat vegetables, you eat legumes, you eat fruits with soluble fiber, you eat dairy products which has carbohydrates and protein, that will be fine. That will be fine. And the ketones, as I mentioned, is a super fuel. In the brain, actually, your brain can function much better by ketones more than sugar. So we need to depart from what is called commercial keto diet to understand what is the science behind it, because there is significant amount of science back to 1920 and the beginning of the last century.
Okay. Thank you very much.
Thank you very much, Dr. Sahir. I'd like to hear from Professor Faisal Shaheen.
مساء الخير.
مساء النور.
Thank you. Thanks a lot. Actually, excellent talk. I enjoyed very much. And I like the comment which you mentioned, Prof. Hussein, and also Prof. Osama, adjust what he said about fasting. Fasting without restriction of water, because we are afraid that we understand from all the nice lecture which we have that fasting is very good for everyone, but fasting for CKD, stage 4, stage 5D can lead quickly to the patient can go for dialysis. So probably we can name it as different thing: fasting with food, about food, and fasting without water restriction. We have too many papers about fasting in transplant patient, fasting in CKD 4 and 5, and it showed that in transplant they can fast, but still in some category of patients, you cannot keep them, especially in the first year, to be fast from food and water. And also in CKD stage 4 and 5, if they have fasting, as we know, the fasting from food and water, this can lead to enhance CKD to be in a phase where they will require dialysis. And we can see it in practice as well. During fasting, we have so many patients in stage 4 and 5, which is they have deterioration in their kidney function very quickly if they fast, especially 16-hour without water for a couple of days. Thank you very much. I enjoy your talk, Osama, very much actually. Indeed, I learned a lot from you today, and I appreciate what Hussein is always doing. Thank you.
Thank you very much, Professor Faisal, for your very valuable points. Dr. Osama, do you like to?
Yes, I'm excited to see Dr. Faisal after all those years. We graduated in the same year from the same school. You know, we met each other for almost 40 years now.
Okay. Thank you.
Thank you.
In general, that's absolutely right. The major issue in fasting with chronic kidney disease is fluids. You know, you cannot fast on fluids, or you can fast. You are actually put the kidney under very, very poor stress. And we see that every day when people are dehydrated, they can go into acute kidney injury. What we are talking here is about fasting, timed fasting or limited fasting or intermittent fasting for food. We didn't touch the water in any aspect. In reality, you need to drink significant amount of water, double what you drink if you are doing the fasting.
Dr. Faisal, one of very important points that we even advise against is nothing per os while we are preparing persons for CT with contrast, for example.
Okay.
I can say to them, don't eat, but they should drink, because nothing per os means no drink, no food. So no drinking means dehydration, and dehydration with excessive contrast, this is very bad. So this is one of the advices that we should stop nothing per os while we are preparing a patient for CT with contrast. Thank you very much. Thank you very much, Professor Faisal. I'd like to hear from Dr. Tariq Tantawi, because Dr. Tariq Tantawi is one of the believer in the very low carb diet. So Dr. Tariq, it seems that we lost him. Dr. Samir Saleh is present, but unfortunately we cannot hear because of technical points. So I'd like to go to, because we have 5 minutes to stop, and I'd like to give the mic to Dr. Refaat again. We'll start the discussion with Dr. Refaat Hegazi, and we'll end by Dr. Refaat Hegazi. Please unmute yourself, Dr. Refaat.
Sorry, guys. Sorry so much.
Yes.
Yes, thank you so much, Dr. Hamdy. Great talk, guys. I think the idea of fasting, intermittent, very low calorie diet, ultra very low calorie diet, they all fit with addressing the issue that we are all facing from, which is adiposity associated inflammation, and that effect on chronic diseases. Dr. Osama exactly highlighted one of the clinically proven, I would say, until we have the more clinical studies. But I think also we have to think of which patient that would benefit from such drastic or restrictive weight and diets, in addition to what stage of the disease, what's the stage of the muscle mass, what's the stage of nutritional status, whether this patient is malnourished or not. But addressing chronic diseases with nutrition is an amazing science that's started to be in the mainstream clinical practice. And Dr. Hamdy is always an advocate and a leader in this field. Thank you so much for a great program, Dr. Hamdy.
Thank you very much, Dr. Refaat Hegazi, for joining us this night. And I hope that we can hear from your experience some interesting issues in near future. And
Sure.
I think applying all this nutritional, and I like the term science, because there is a great difference between science and fiction. So doing the nutrition with the guide of scientists makes a great difference. And the last point on the chat is obviously pre-diabetes. I think if we advocate fasting, intermittent fasting, cutting calories, improving carbohydrate quality, this will be a good armamentarium against pre-diabetes. I'd like to hear from Professor Osama Hamdy about the issue of pre-diabetes, and this is the last point.
Yeah, definitely pre-diabetes and metabolic syndrome is a whole issue that we are facing right now. You have 3 or 4 times people with pre-diabetes than people with diabetes now, and many of them will develop diabetes in the future. And up till now, diagnosis of pre-diabetes is much lower in the entire Middle East area. Maybe 1 in every 10 is diagnosed. The number is keep going up. Obesity insulin resistance is a major problem, which is a core also of the metabolic syndrome, which can lead to cardiovascular disease, even if people didn't develop diabetes. And the best way to prevent that disease, as we had seen in diabetes prevention program, is weight reduction and lifestyle modification. I was one of the investigators in diabetes prevention program, and I remember how the effect was very obvious, even with a very little weight loss. And the study showed that with 7% weight loss, which we aimed at, reduction in conversion from pre-diabetes to diabetes is down by 58%. So lifestyle modification can be of huge impact. The whole idea now is how to maintain it for longer duration, how to maintain muscle mass during weight loss, how to preserve basal metabolic rate, how to increase energy expenditure, how to scale it to be implemented on a bigger scale. United States now are using digital programs. Many digital programs are available now, and they are very, very effective. And the cost effectiveness and the return on investment is very, very high. So that's why United States are investing significantly in diabetes prevention program. Many countries are doing the same. And I hope in the future in Egypt and the Middle East, entire Middle East, we need a very efficient diabetes prevention program. If we do this, hypertension will be lower, diabetes will be lower, and definitely chronic kidney disease will be significantly lower. And I hope in the future that some of those programs can be implemented in a very, very efficient way if we identify those people and help them to lose 5-7% of their body weight and maintain it. And we know how now.
Thank you very much, Professor Osama, for this elegant talk about the novel nutritional technique. And I think after adding your talk to the YouTube tomorrow, I think at 2 p.m. you'll find it already released to the YouTube, and it will enrich our virtual Academy of Nephrology. And this is now we reached this number of lectures and videos, huge amount, and I think it will enrich our scientific academy. This is a very small symbol of appreciation, respect to your presence and your fascinating talk, Dr. Osama, in recognition of your contribution. This is a symbol of appreciation from the Egyptian Society of Nephrology and Transplantation Continuous Medical Education chapter about your presence with us this night. And I think a changing lifestyle, I'm believing in lifestyle, because lifestyle, it is very difficult issue to change the human behavior. But if we succeed to convince people about the poor lifestyle, this will make a great difference. And I think this is one of your favorite slides, and we like, as you like Egypt, we love you very much and hope to meet you again and again. Also, I'd like to thank Professor Megahed for his presence and for discussion. I missed the discussion of Professor Samir Saleh because of technical reason, but I appreciate his presence with us. Professor Refaat Abdel Fattah Hegazi, I admire his style of discussion, and he is really an expert in the field. I would like to have him with us speaking about one of his important perspectives in the field, because we are, at the end of the day, we are medical persons, and we will learn a lot from experts like Dr. Hegazi. At the end of this session, again and again, I'd like to thank and appreciate the presence of all my professors, colleagues, especially from African countries. And I'd like to leave the mic for the last words from Professor Osama Hamdy.
I will repeat again that let food be the medicine and let medicine be the food. And I think we had ignored that fact for a very long time. And I think if we are using a better nutrition now, I think the future will be much better. Thank you very much. And thank you, Dr. Hussein, for this wonderful organization. And I'm glad that the digital concept helped us to reach every one of our colleagues. And I hope this will continue, and congratulations on your success.
Thank you very much, and goodbye.